Thank you very much. And first of all, thank you so much for our patient partners, keyword partners, for taking the time to, and for your courage for coming up and speaking about your experience. So thank you very much. And it certainly left me with a tough act to follow. But I have been tasked with speaking about empowering our patients through exercise, and I'd like to thank the planning committee for the invitation to come and speak. And I'd also like to thank specifically the CDTRP and Big Gifts for Little Lives for their support of a lot of the work that I'll discuss in this talk. So thank you very much. I have no other disclosures. So we're very grateful that short and medium-term post-transplant outcomes continue to improve across eras, and this is shown from ISHLT annual reports that have shown with increasing eras, so the purple line being the more recent era, though this needs to be updated, that the outcomes continue to improve. But with these improved short and medium-term outcomes, there's been a shift in the focus somewhat towards promoting long-term survival and addressing impeding risk factors. And one of these key long-term risk factors is exercise capacity. This has been shown in numerous cardiac and general medical populations outside and within transplantation, including this work in adult heart transplant recipients, where exercise capacity as measured by VO2 or oxygen consumption, a measure you'll see later on today, is significantly associated with survival post-heart transplantation in adults. Unfortunately, we don't have data to this degree in the pediatric world, but we do know that children following heart transplants and also children in other solid organ transplant populations have reduced exercise capacity. And why is that? Well, there's numerous biologic or anatomic and physiologic factors that are beyond the scope of today's talk, but that includes skeletal muscle weakness, deconditioning over time from their pre-transplant care and the immediate post-transplant period, vascular dysfunction, the need for chronic immunosuppression, including at times chronic steroid therapy, and then also reduced physical activity, which I'd like to focus on a little bit more. We know from our clinical experiences, but also from some of the science that children after a heart transplantation are not as physically active as other Canadian children are, and they're not as physically active as we would like them to be, because it's important to mention that Canadian children at baseline are not as physically active as we would like them to be. And in this study that was out of sick kids from a number of years ago, of 20 children who were pediatric heart transplant recipients, they had undergone exercise testing. Their peak VO2 was at 65% predicted, which is about consistent with what our work has shown and other work across numerous studies. But importantly, when they were given accelerometers to objectively measure their physical activity, the median physical activity levels for moderate to vigorous physical activity, so for those of you who don't know, that's when you're a little bit breathless as you're exercising, was only 7.6 minutes per day. Which is quite low because Canadian recommendations are for 60 minutes a day, every day. And importantly, all 20 of the participants in this study failed to meet current Canadian recommendations for moderate to vigorous physical activity. And other work has also explored some of the factors that are leading to this, including functional status, abilities, and muscular strength. And this was work that was led by Dr. Simon Urschel at the Stollery Children's Hospital, where in 22 heart transplant recipients, 6 kidney transplant recipients, and 20 control or non-transplants, they underwent 6-minute walk tests, muscle strength and endurance assessments, including things like push-up assessments, and really found that 6-minute walk test results were lower for patients that had received heart transplants and kidney transplants compared to the quote-unquote healthy controls. And numerous tests, including things like the wall sit time, which is where you sit against the wall in a squatted position, were lower for the heart transplant and kidney transplant recipients as well, though there weren't, for many of the tests, dramatic differences between the heart and kidney transplant recipients. And importantly, the wall sit test had correlated nicely with other fitness parameters and also questionnaire assessments of quality of life, suggesting that, when we take our vital signs in our kids, maybe we should also have them do wall sits as well, but perhaps only if the cardiologist does it with them, huh, Simon? I wonder. and get a workout in clinic as well. And you know, so why is the physical activity levels lower? Is it just because of ability and strength, or are there other competing factors or interwoven factors? And a key, and this has been studied to a significant degree in the congenital heart disease population, but far less in the solid organ transplant population for pediatrics. And qualitative and quantitative research has demonstrated that children often feel, and their families often feel, restrictions that are imposed on them by the medical team, by their family, by teachers and coaches, or the patient themselves. And these may be real restrictions or perceived restrictions. With this, they may have feelings of exclusion, they may have health-related anxieties, negative perceptions from their peers, and the parents can feel a sense of loss of control often. Which we just heard about. And all of this culminates into a reduced self-efficacy towards exercise. Self-efficacy is an important term that I'll keep coming back to, and it really means a patient's confidence in their ability to participate in something. So how confident are they in their ability to exercise? And in prior work that had looked at this validated questionnaire, the CSAPPA score, which is a self-efficacy assessment, you can see that in more severe forms of congenital heart disease, the score is lower, and it actually also corresponds with a lower level of physical activity, but also a lower peak VO2. And in adult transplant recipients, this self-efficacy is also linked with feelings of inadequacy and inferiority. And this may be because of post-transplant psychiatric concerns, such as depression and other mood concerns, which are quite common, the requirement for chronic medication use, including immunosuppressants, activity limitations that are put on them, possible learning difficulties and cognitive impairment that may feel that it impedes their ability to participate, physical appearance concerns, and then awarenesses of their differences and worries about lack of acceptance by peers. But the study of this in pediatrics is really currently underwhelming, unfortunately, and requires a lot more work. And a link to this idea and related to self-efficacy is the concept of psychological distress, which we were just hearing about, and how this actually applies to the children and how this can prevent them from feeling empowered. And distress itself is a very strong predictor of post-transplant quality of life. And self-efficacy in the adult work has been shown to be inversely associated with depressive symptoms and uncertainty post-transplant. So if you are able to address depressive symptoms and these uncertainties that arise, you know, as was being just suggested right now, then perhaps you can improve self-efficacy, which in turn can improve physical activity and empower our patients. And so the presence of a sense of a lack of accomplishment has really come out as being strongly associated with self-efficacy in adult transplant recipients, and that includes physical lack of accomplishment. And so one of the larger studies that have looked at this concept was in nearly 500 adult renal transplant recipients. And using questionnaires, they measured a validated assessment of fear of movements. And then they also used other questionnaires to measure self-efficacy towards physical activity. And somewhat not surprisingly, they found strong associations between self-efficacy and fear of movement. But then they took it one step further and they demonstrated that those that had high fear of movement scores, which are the gray bars on this curve, on the bar graphs, had lower physical activity levels across all domains. So to summarize the problem and where we're at, we know that pediatric heart transplant recipients have reduced exercise capacity and reduced physical activity levels. And among other factors, this may be at least due in part to reduced self-efficacy and empowerment. So what can be done to address this? Well, cardiac rehabilitation is an established secondary prevention strategy in adult cardiac patients in general, and it shows improvements in all-cause mortality, cardiac mortality, and hospitalization. And this has also been studied in solid organ transplant recipients, including in this meta-analysis across 21 randomized controlled trials where there were improvements in exercise capacity, muscle strength, and health-related quality of life. And I wish to highlight this study because it was a fantastic randomized controlled trial in heart transplant recipients, adult recipients, that had compared different modalities of exercise interventions, high intensity interval training, or HIIT, which I'll come back to in a moment, and moderate intensity continuous exercise. And they demonstrated that across a 9-month intervention, improvements in peak VO2 in both the moderate group and the HIIT group but the between group difference was significant, where the HIT group had greater improvements in VO2 compared to the moderate group. But we have a number of knowledge gaps. That's the theme of today, a number of knowledge gaps in the pediatric population. We know that exercise interventions remain largely understudied. There's a lack of randomization in those studies. There are no studies that have evaluated HIT in pediatric transplant populations. We also have an understudy of home-based telemedicine interventions, and we don't know what the long-term impact and sustainability of this work is. And it's really important to emphasize the role of home-based interventions here. As many of you know, at the Stollery, we provide transplant services for much of Western Canada. And so having a traditional cardiac rehab program that takes place in the hospital in Edmonton really doesn't apply to the vast majority of our patients, even those that live in Northern Alberta. But home-based programs, while they're appealing and they're accessible, they don't allow for that real-time monitoring and supervision of our patients, monitoring adherence to the exercise regimen, but also form and safety. Whereas telemedicine interventions with real-time physiologic monitoring, which is this middle curve of this Venn diagram, really bring together the best of both worlds of a facility-based program, but allowing the convenience, cost savingness, and accessibility of a home-based program. And so with the support from the Heart and Stroke Foundation of Canada, the CDTRP, and Big Gifts for Little Lives, we've been working with a telemedicine device to address a lot of the pediatric knowledge gaps that exist to date. And so this is the MedBIKE, which is a custom telemedicine ergometer. It's a bike this is a transplant recipient, and the bike is set up in his basement. So he's at home. The bike is attached to a trainer, if you can see my mouse. And then he's also attached to a video game, or he's in the video game world. So if he steers in this world, it steers as well. And we have live video and audio communication. So you can see in the bottom corner, somebody is supervising him and coaching him, essentially serving as a de facto personal trainer. There's ECG monitoring. So under his shirt, he's wearing ECG leads that can come through to us. And we're putting the kids through high-intensity interval training programs. So when they're in an interval, you can see he's in this wormhole, and he's chasing what appears to be a stegosaurus here. And if he bikes fast enough, and he maintains the cadence that we set for him, he gets points. And if he gets points, he can buy new avatars. And he can actually also compete with other kids. And so it becomes this sort of gamification of exercise. And we've been putting kids through a 12-week protocol for 36 sessions. So quite intense of one-on-one exercise. And this is what it looks like from our end. So we're in the hospital, we're not in his house. He's wearing the ECG leads. His ECG tracing is coming across. And if I stop talking for a second, you would hear our kinesiologist coaching him, serving as one-on-one training. We can see his vital sign parameters here, but most importantly, we can modify the resistance from our end. So after each interval, he tells us on a built-in tablet how difficult was that interval. And if he says it was too easy, bring it on, then we increase the resistance and we make the next interval harder. And if he says, oh, come on, go easy on me, then we make the next interval easier. And so the goal across the 12-week program is to increase the resistance with progressive overload, much in the way that you should in the gym. Okay. And so I'll briefly go over the study, which is it's hopefully near completion of recruitment. But this is a feasibility study and a safety evaluation of a randomized crossover trial of a home-based telemedicine HIT program in pediatric heart transplant recipients. And so we had an a priori definition of what feasibility was, including enrolling over 60% of eligible participants, high session adherence of over 80%, a low dropout rate below 10%, and no adverse events related to the intervention. Our secondary objectives are looking at measures from the exercise intervention itself based on pre and post cardiopulmonary exercise tests, looking at measures of exercise capacity, physical activity, self-efficacy, which I've been emphasizing here, health-related quality of life, and sustained changes at 6 and 12 months. So I won't go through all the exclusion criteria, but rather I'm showing you that there's a long list, and this is important because with any exercise intervention, you have to, as clinicians, then subsequently think, how does this apply to my patient? This may not necessarily be applicable to all transplant patients. So when I tell you we didn't see any adverse effects, spoiler alert, it doesn't necessarily mean that this would be safe in all pediatric heart transplant recipients. They still need to be gauged. but we're recruiting 10 to 18-year-old pediatric heart transplant recipients that are at least 6 months post-transplant. So the participants come in and they have a baseline cardiopulmonary exercise test to measure the secondary outcome measures, and they also receive the accelerometer and also complete questionnaires. And then they're randomized to either go into the immediate MedBIKE arm or a control arm, which is just carrying on with usual care. But have no fear, if they randomize to the control arm, then when they come back in after 12 weeks, they cross over to the MedBIKE arm. So everybody does essentially serve as their own control while also still entering into a more traditional RCT. And then after that, there's a post-MedBIKE assessment and then follow-up assessments at 6 and 12 months that occur. So currently, we're nearing completion of our recruitment of our feasibility study. 8 participants have completed the entire MedBIKE intervention, and about 4 participants have had at least 6-month follow-up data. I'm not going to present any of the the changes in exercise capacity today, but just to mention that, that we should have those results, hopefully, at least preliminary results, published in the next year, and they're quite exciting so far. What we have seen, and very notable, is that of the 8 participants who have completed the program, there's been no attrition or dropouts, which means nobody has stopped the exercise program. And each participant has completed at least 34 of the 36 sessions, with most of them completing all 36. And this is important because if you look at most exercise interventions, usually adherence to the protocol is in the 50 to 75% range at best. So to have 95% or above has been great. And I think a lot of that is because it's one-on-one or effectively working with a personal trainer. And also importantly, we've had no adverse events related to the intervention across the 8 participants in 36 sessions each. And we've received comments like this so far, so we wait to see what our self-efficacy data is, but this was a participant and who had sent a text message to our research coordinator, Ray, who said, just want to share with you so-and-so's achievement. He was able to bike 44 kilometers from Canmore to Banff round trip this past weekend. I think the MedBIKE program trained him for that, and thank you for the whole team. Feel free to share this. So to close, we know that pediatric solid organ transplant recipients have reduced exercise capacity and physical activity levels, and that empowering our patients and promoting self-efficacy may lead to long-term improvements. Dedicated exercise interventions must evaluate changes in self-efficacy as a key endpoint, amongst other patient-reported outcome measures. And I close by emphasizing that, if you could put exercise in a pill, it would be much more effective than many of the medications we give our patients. And so at each visit, we have to focus on transitioning from and continuing our transition from exercise restriction towards promotion for each patient at every visit. Thank you very much.